Well, thank you, Allison. It's lovely to share a stage with you again, and it's an honor to be here today with all of you, and I'm excited to see how our discussions go. We're going to get started with our first speaker, and this is Kevin McAvey, is Director of the Manatt Health Strategies, where he advises states across the country on how to develop and use health data capacity to advance policy, program, and regulatory goals, including fostering market competition and innovation. Kevin works closely with leadership at Medicaid, social service, public health, and insurance departments to develop comprehensive data and analytic strategies, and with philanthropic leaders to design investment strategies that catalyze market change. Kevin is widely published on the topics of healthcare data, data exchange, and data use innovations, and designing systems of healthcare that are ready to meet the needs of a data-driven future. Kevin?
Good morning, good morning. It's really wonderful to be here today. I was debating whether to wear a tie this morning, and I took the risk and didn't wear it, so I'm just going to imagine all of you not wearing ties. That better? Okay. So, tie-less this morning. I'm really pleased to be here. I've been the title, thinking of the title of the presentation. I did decide to kind of put down notes from the field, and that's because day to day I've been working across the country. Yesterday I was 2 days ago I was in Albany. Today I'm here. Tomorrow I'll be in D.C. and in Iowa, and the following day. And there's so much going on, and so much really good new capacity being developed across all of our states, and it's just, I feel privileged to be able to work in the role that I do. And I also have to say, and this just kind of reminds me of us as we come together today, how nice it is to see people in person again. I don't know about you, but I just feel like we are, and I'm not a big people person. I'm a very much at home person in my preferred life. But I think over the past few years, we've grown hungry and thirsty for that human connection, the sharing of ideas, and we have to remember that opportunities like this provide us more than just kind of information on a slide, which you can get from a webinar. It's the ability to make connections, and in our case, like across the healthcare system, from payers, providers, the states, really think about how we're going to be solving problems. And as we'll talk about today, in my perspective, so many of those problems start getting resolved by actually understanding what those problems are. Starting with collecting data, translating that data into information, then applying it into the actions that we collectively need to take to make sure our healthcare system is performing as we want it to. And so that's what I'd like to talk a little bit about today. And I know as I asked, sure you want to kind of open with data? It's not 8:30, 8:45 in the morning, but we'll try to keep it a little interesting and spicy. But first thing I want to mention is I always like to and failed to in the past introduce myself, and I think you should always know your messenger. I'm Kevin McAvey. I'm a director with Manatt Health. I work across the country. I've been a health data nerd for a very long time, 20 years. I started off as a certified programmer to an analytic need. I worked for the state of Massachusetts, and now I'm a consultant for whatever that means. I help people solve problems. I'm a health data evangelist. I believe that markets work better and policymaking is more effective and limited when we have better access to meaningful system information. But I'm also a realist. A lot of times we will see folks get up on a stage and talk about broad system redesign, and I love it, and we need that. but I can't help to get like a pit in my stomach every time being like, oh my God, do you know how much change and work that requires from so many people? From the legal and regulatory changes we need, operational technical reforms. There's every kind of aspirational change, and right now we're amid several of them, from whole person care to addressing whole social determinants of health, health equity, require deep system changes that require work from all partners in our healthcare system. And as my wife likes to remind me, I have kids, and they are the loves of my life. And my wife asked me to put this slide up there to, as she so kindly put it, humanize me. So whenever I say anything through this presentation today that you might find distasteful, know that it's not intentional, and they like me, so please, I hope you do. I hope you do too. But I do want to start off with just telling a broad story to bring us down to kind of the health data weeds. Our healthcare system is not working as we want it to. I'm not going to be talking about major reforms or solutions in today's presentation because that's not my role. But I do want to emphasize that it is our healthcare system. There is, whether you're talking about the providers who care for us, who are there when my wife called me before, like my son had a little scratch and his eye was swollen and he went to the doctor. Like these are the folks that take care of us every single day. They are not... We are all partners together in making our healthcare system better. The payers who are proactively, thank you, managing care, thinking about novel ways of identifying early risk indicators for our patients so that way we can intervene early. Whenever we think about a healthcare system that's not working, I try not to think about who is to blame. I think about what rules do we need to change to make sure that we're all working together. If we do not fix the system, I do believe we are destined for broader and potentially suboptimal system change being imposed upon us. We've seen it. It'll happen again. We cannot fix a system we do not understand, and to understand a system, we require information about its performance, how it is delivering services for those who pay for it, and to what effect. And we have more data about our healthcare system available to us than ever before, but we are still learning how to harness it, and we're still learning how to translate it into useful information to support market transparency and evidence-based policymaking. And so I'm just going to start on this first point to set us up, and I think many of us know these statistics, but it's always helpful to just kind of ground our conversation in them. Over the last 2 decades, our national healthcare spending has nearly tripled, growing faster than national income to comprise almost 1 out of every $5 of our country's gross domestic product. National healthcare spending is projected to continue to outpace GDP growth. Last year or 2 years ago, with COVID spending, it hit 1 out of every $5. It's going to continue to grow up to that amount again. And every dollar that goes into healthcare spending, for better or worse, and we're not making judgments here, that is one less dollar that can go into other priorities that each of us have as members of our family. And we are not always seeing the return on investment. Despite spending nearly twice as much on health, the U.S. has lower life expectancy than comparable nations, and this gap worsened and accelerated during the COVID-19 pandemic. And we do not all interact with the same healthcare system. I can talk about, and we have a whole deck of 40 slides that talk about the health inequities and disparities we face across the country in every single state, whether we talk about race, ethnicity, geography, income. We do not all interact with the same healthcare system. So, let's get into it. We have more data about our healthcare system available to us than ever before, but we are still learning how to harness it. So this is a lot of shit, a lot of stuff. We have a lot going on right now in the environment right now, and I don't expect you to understand or kind of track everything that's on this slide, but I did want to emphasize a few key points. Do not get distracted. We have to always start with identifying what information we need for our policy, regulatory, and business decision-making goals. And then we need to think strategically about whether we can use existing data or whether we need to build new data collection and analytic capacity. And finally, I just want a reminder to be kind. And this is coming from, this is something I kind of held in my day-to-day when I was in Massachusetts working to develop some of the programs we're going to talk about today, when I was working with payers and providers. Payers and providers are, and there are so many in this room, are not, their top priority is not getting you the best data they possibly can on a daily basis. Their priority, as it should be, is taking care of patients and working with them and understanding all that they have on their plate only reinforces the fact that everyone, again, as partners in our healthcare system, wants our healthcare system to work well for everyone. But sometimes we just need to remember to be kind when we're asking for information for one another to better understand what the problems are and how to fix them. Again, a lot going on, a lot of stuff going on. We're going to talk about a few of those things. And so to think about, again, in the spirit of thinking about use, the questions we have and how we want to answer them, and how the data resources many states across the country are investing in to answer those questions, I wanted to set us up with a little bit of a framework here. Healthcare affordability, how much are we paying for healthcare services? System performance, how effective and efficient is our healthcare system in delivering services and improving health? Population and public health, how is the health of our population changing over time? What health and social determinant of health factors are influencing health outcomes? And then I'll close with a few thoughts on our healthcare workforce. What are our state's current and future healthcare workforce needs? Where are we seeing persistent occupational vacancies? Where are we likely to see significant healthcare workforce shortages? So I'm going to talk about, there are so many things I could talk about today, and I'm probably already over time, but I'm going to do a deep dive on cost growth benchmarking data and all payer claims databases. I think a topic of recent conversation I've heard. Price transparency data, as you'll hear it come up in day-to-day conversations. New health information exchange expectations, and then again, I'll close on workforce data. We're not able to fit in financial reporting and SDOH identification, both fascinating topics, and I'm happy to talk at any time. But we only have a couple of minutes today. So, cost growth benchmarking data. State policymakers are increasingly pursuing cost growth benchmarking programs in lieu of more prescriptive policy fixes. Cost growth benchmarking programs provide data that can be used to design and inform strategies that help to contain the rate of state healthcare cost growth if they have measures of accountability tied to them. But for me, I really care about the data. Healthcare cost growth benchmarking programs are data-driven initiatives that provide states with baseline information about their healthcare costs and cost growth in relation to established targets. I'm going to come back to this slide, but what it does is right now in every state, including Kentucky, data is collected by various entities, various departments across the state for different parts of our population. The insurance department collects information on the fully insured part of the market. To the extent you have a state-based exchange, you're getting data from the federal facilitated marketplace. You have data for that population. Medicaid, the state Medicaid agency houses that information, and then you can get data on the Medicare population from CMS. It's all collected in different ways with different pieces of data that provide different information for different purposes. Cost growth benchmarking programs collect all of that data in one nice, neat little tidy whole. So that way you can understand, and for your healthcare system writ large, where dollars are going. Like who is paying the premiums or who is paying the tax dollars that go into the system, and how do those dollars trickle down to payers and to providers. And for a provider-attributed population over time, how those costs are changing. Now, I'm not going to talk about whether the cost growth is too high or too low in this presentation today, but I think that many in this room would probably want to know that information. Like where are our healthcare dollars, which continue to grow every year out of all of our pockets, whether paying directly through premiums, through our employers who are paying 3/4 of our premiums, through our tax dollars. Where are those dollars going? What is our return on investment? I think these are core questions that these new state programs seek to address. And as you see on the right side, or you can try to see, my eyes are getting really bad. You can break out, and cost growth benchmarking programs can break out cost growth across different payer types, whether we're talking about Medicaid, privately insured, or by plan type, HMO or PPO for the private part of the market. They help to identify health system cost centers and health system cost drivers and their impact on coverage and affordability. They help to identify the rates of alternative payment rate adoption, APMs, in the market, and service spending priorities, and our level of spending on things like primary care and behavioral health across payers. That allows us to also think about how are we investing in these preventive services compared to other states, compared to our own priorities. Benchmarking programs may include regulatory mechanisms to support market accountability to those targets. And states may pair benchmarking data with other data, such as APCD data, to strengthen analyses, do deeper dives. And we'll talk about that in a minute. Having the capacity to collect, assess the quality of, and analyze healthcare spending data is a critical component of benchmarking programs that allow them to inform state-specific data use goals. Payers may be asked to segment data by service category, key populations or product types, and attribute spending to providers, again, all within the spirit of tracking spending for a specific population over time and how it changes. And payers may supplement core reporting with contextual information about a population, about plan design, to see the penetration of high-deductible health plans in a given market, for example. Payer submissions are sourced from a combination of their administrative data as well as from their non-claims-based data. And they're proliferating. So I heard in a conversation that happened a few months back, folks were talking about, I think the term socialist was raised about folks up in a certain state, Commonwealth of Massachusetts, who designed these crazy programs. But when you think about that, I just want you to think about go. This, because I was that person. I was that person in the back room in the night when everyone else when many others were gone, in the dark, really thinking about how we are going to collect data so that way we can better understand our healthcare system. And that's where it starts. Everything else that happens after that is up to you, and it's up to the state policymakers that get that data, who are seeking to understand that problem and who want to resolve, whether it's how we can improve health to how we can better control our spending growth. And that program that we designed in the dark rooms in Massachusetts has spread first to Rhode Island and Delaware. Now I think we have 11 states. My colleague messaged me yesterday, and she's like, Nevada doesn't have it anymore, but Utah does. And so it continues to grow across the country with, in the past 2 years, California, Minnesota, and Maine, and now Utah adopting programs. And these all don't have to be by top-down design. The program in Utah, for example, is an industry public-private partnership where payers and providers in the system are working through a nonprofit who is convening these private sector entities and government to really think about how we can collect data to better understand our healthcare system and hold ourselves accountable to a target, to a goal, to constrain costs moving forward. Now, there are different dimensions of setting up a cost growth benchmarking program, which I won't go through here, but in the spirit of what Utah is doing and what other states are doing, I just want to emphasize that there is a spectrum of how this data can be used depending upon your local policy priorities. On one end of the spectrum, there are states like California that have recently introduced accountability provisions for payers and providers that exceed the target multiple years in a row of escalating penalties, from public naming and shaming to performance improvement plans, and ultimately potentially financial penalties commensurate with the amount of the overage. If healthcare cost growth spending is expected to grow by 4% a year, and for your population you're not able to keep under that 4% per year by better managing their care, and by the way, this is health status risk adjusted, you are expected to testify and say why. It provides a certain check on healthcare system spending that previously hasn't been in place because of our regulatory system is often so fragmented. On the other side of the coin, and the other side of the spectrum here, states like Utah, Connecticut, Delaware, Rhode Island are largely focused on transparency and accountability through that looking at our numbers together and being accountable for those we serve. I have no religion on either, but I think it's ultimately up to the individual states. These cost growth benchmarking programs also allow states to do something else besides collect data and reflect it back to the community. It allows and facilitates a conversation that's too often lacking in our states about what we're spending our money on, what we're spending our healthcare dollars on, for what services, to what end. It allows states to convene stakeholders across the public and private sectors to discuss those issues and develop resolution strategies. I've written a bunch about this, so if you want to take a look at it, it's all on our website. And I want to talk about next APCDs. So cost growth benchmarking programs, top-line data about our healthcare system and where spending is growing, where dollars are going. State APCDs are much deeper data resources. And I'll put this up front, they're often de-identified when they are used. States are increasingly de-identifying this data to proactively address privacy concerns before the data even gets into their analytics shops. So one will hear arguments all the time, two things, like why do we need an all-payer claims database? And I'm going to tell you, I'm going to let you in a little secret. There are already state all-payer claims databases for Kentucky, across the country. If I wanted claims data on virtually everyone in this room, I could get it, because there are private vendors today who are selling it and who are making a ton of money selling your information to the private sector so that private sector actors can better compete with one another. Anyone who says we don't need an APCD is either just not fully aware of what's going on in the environment, or does not want to address the extreme information inequities we are confronting right now in this country between the information that the private sector has and what the public sector and consumers have available to help inform our decision making. I'm not going to take many stances in this presentation, but I will say I don't think that's right. I don't think every state necessarily needs an APCD, but I do think there are information inequities that can and will be addressed. The other thing that you'll hear in conversation is about patient privacy and protecting patient privacy. I work with state health data organizations across the country. I work with Medicaid agencies. You ask them what their top priority is on a daily basis, it's protecting patient privacy. They adhere to standards that go above and beyond what legally they are required, I think virtually to the one, what they are required to do. This is a top priority, and I wish I could say the same for some of the private sector data that I was referring to and how that's handled. So APCDs, I wrote a paper. It was supposed to be like 6 to 8 pages, 160 pages. It talks all about this stuff. So if you're ever looking for bedtime reading, or it's really true bedtime reading. But for those who are uninitiated, what is an APCD? APCDs are large and complex repositories of healthcare claims and encounter data for individuals receiving healthcare insurance through most public and private sources. Blah, blah, blah. You go to the doctor asks for money based upon negotiated rates with a payer, assuming a fee-for-service billing arrangement. Those dollars go back. The receipts for all of those services go to a state APCD along with membership and claims data submitted by state specifications. And that's for all the payers in the state who are above a certain threshold level. That data is then cleaned, compiled, normalized, linked as necessary, and de-identified for analysis. And then someone at the other end is looking at it and trying to make sense of it, produce information to inform policymakers, to inform regulators, to inform consumer groups, to inform some of my best and most frequent, I want to call them clients, or like folks that I worked with in Massachusetts who are using the data on a daily basis, were actually payers and providers, really understanding like their positions in the market. We produced this penetration atlas that really kind of looked at where membership was across the state and where dollars were going for that membership. And let me tell you, it actually saved many of the payers and providers significant sums of money that they were paying for these private claims data vendors to run the same exact analyses. It doesn't always make sense, so you're just that's not my field. So the model itself, high level, again, payers submitting common data standards up to a vendor. There's the data collection, curation, reporting, release process. This can be a pretty nimble operation. I can talk about, and I'm not talking about today, but I can talk about like how much it actually takes to set up and finance an APCD agency, or an APCD within an existing state agency or an independent one. But what data is included? Just to level set here, generally included, fully insured part of the market, marketplace plans, Medicaid fee-for-service, managed care plans, Medicare Advantage, state and local health benefit plans, sometimes included depending upon the state fee-for-service data, Part D data, dental plans rarely included because of federal restrictions, ERISA, preempted self-insured plans. This is something I work with a lot of major employers and group purchasers across the country, and they've actually started setting up their own multi-payer claims databases just to share their self-employed data so they can better understand and negotiate network rates. It's a limitation across states right now, and the federal government's very aware of it, and we're going to talk about that tomorrow. State APCDs, in addition to the important service, payment, and clinical information that might be on a claim or an encounter record, they also usually have contextual information about the member. For state APCDs, you have diagnosis codes, understanding where who billing and rendering providers are, services and prescriptions received, payer paid and patient paid amounts, as well as like individual and population characteristics, gender, age, zip code. You'll note I left off race and ethnicity off those because, as some of us might know, it's really crappy on claims data. But there are novel tactics that state APCD agencies are using to better understand, better equip their APCDs to address questions around health equity including imputing community characteristics back to the data to understand down to the local tract level who is being served and who is being underserved, who has access to primary care resources, behavioral health resources, and who does not. Provider information, plan characteristic information. And APCDs are not a blue state or a red state thing. This is a map of state APCDs in 2013, and this is a map of APCDs in 2023. The last 4 states to, let's see if I can do this, to pass APCD legislation. Fine state of Texas, Georgia, Indiana, Alaska, all because they want to better understand how their populations are being served. They want to start to address the information inequities that they observe, because when they call up folks to testify about why healthcare costs continuing to rise, why are we continuing to see inequities in disparities in health? Why are we continuing to see challenges in access to care? Those providing testimony often have really wonderful data. Those on the other side of the podium often do not. And that, again, is a little spoken to, but pervasive truth, really dull, boring, pervasive truth in our country right now. APCDs offer policymakers, regulators, researchers, purchasers, and consumer advocates a unique tool to better understand how our systems of health are performing to inform their goals and decision-making. They create and provide baseline statistics of health insurance coverage, utilization, costs, cost trends, outcomes, help to identify inequities, support regulatory oversight. I saw a really cool analysis in New Hampshire of testing network adequacy standards. It's kind of like a heart beating through the body when you look at claims data and you see these black patches. I just think of, anyone ever watch House? It's like, that's where the problem is. But that's how just these novel use cases that continue to emerge across states when they have and they are equipped with information about their healthcare system. Their APCDs are also increasingly being used to understand whole person health needs as the backbone for further analyses. This was a use case that's kind of near and dear to my heart. Massachusetts, enrollment trends over time. One thing APCDs do allow us to do, because it has such a wide swath, about 2/3 of our state's populations in there, it allows us to look at patient migration trends, not only over time, but between coverage types. So I think a question on many folks' minds right now, like Medicaid redetermination, like where are people going? Are people just dropping off into the ether? We hope not. We hope that over time, these drastic reductions that we're seeing now are just a result of someone going back into the employer-sponsored insurance market. APCDs are uniquely equipped to understand where members are going between health insurance plans and types. The impact of health system reforms. We just passed that thing last year. Is it actually having the intended outcomes? Or do we have to survey payers or providers, putting more burden on them to get piecemeal information about its effectiveness? Too often we're relying upon outcome measures, like we see a lot of sick people. We see a lot of people who are uninsured. Like, how nice would it be to really kind of understand how the system is operating to understand how we can fix it? In Colorado, Civic provides information on Colorado's healthcare cost drivers and opportunities to afford the affordability. That's not a thing. To improve affordability. They track APM payments. 10-minute warning. It's for me. They track alternative payment methodology adoption across different payment types in the market for the member and the claim level. And then for those of you who don't know Dr. Joe Thompson, you should know Dr. Joe Thompson in Arkansas. Arkansas Center for Health Improvement, an independent health policy organization, administers and uses the Arkansas APCD to profile all sorts of things. Whenever a policymaker or a legislator has a question, they aim within 3 days to get to an even directional answer, which is just an admirable goal. And what's shown up here is the annual change in opioid prescriptions in Arkansas, and this data is used to inform actual state responses, policy making, public health responses. And what's amazing to see across these states as they set up these data resources, whether it's the state cost growth benchmarking programs or the APCDs, is the flywheel effect. And what I mean by that is when these databases are often set up, you have the true believers, and then you have those who are kind of on the fence and not sure. It sounds like a waste of money. It sounds like a really big risk for whatever that means. And then they have a question, and they go and they ask a question of the agency, and they get an answer. And then they have another question. And then they go and they ask that question, and they get an answer. And I think the more we do that, and as states who have adopted these data resources have done, the more we get to the bottom of some of the problems in ways that we haven't, our healthcare system problems, in ways that we haven't been able to previously. And so I heard a phrase Kentucky needs an APCD like a frog needs a bicycle, and I just couldn't let that go. So I did find this little postcard here, but I'll leave it to you for the final determination. I know I have probably about 7 minutes left now, but I wanted to touch on a few other kind of data disruptors that are going on across the landscape and that I'm working with states on and purchasers, others. Just so that when you hear them in conversation, you have some context to that big mess of stuff I showed at the beginning, to really understand its impact on the environment. Price transparency data, CMS and ONC have required, and God bless them, under the Trump administration, the disclosure of all negotiated rates for hospitals and payers. This was previously proprietary, like heresy. You want us to share our negotiated rates? They're all legally supposed to be out there. The hospital data has low but increasing compliance. The payer data is out there, and they took a different strategic tact and just threw everything at the wall. So the files are ginormous, but luckily I'm pretty good at coding, and you can unpack them, and many firms out there have unpacked them and are deriving new information about our rates. Building on studies like those of the Rand Corporation that showed the significant price variation across payer types, from Medicaid to Medicare to commercial. Now, using some of the price transparency data, we're even able to parse that further, to really think about, like, for those in this room that are self-insured, and if you are employed by your insurer, about 61% of you on average or so are self-insured, you might actually be paying higher rates than what your fully insured counterparts are paying at the end of the day for healthcare premiums, which is something like I didn't believe a couple of years ago. I'm like, of course the self-insured are paying less. No, but that's what this data actually does. It empowers us with more information to ask why, to push harder, to push further on our healthcare system that's not delivering for us. Price transparency, it's changing the competitive dynamics, and you're going to continue seeing it changing the competitive dynamics across the country. HIE expectations. I'm in California right now helping to set the rules of the road for health information exchange across the state, and they put out a law that requires most healthcare organizations to connect to and share data with an HIE to make sure that when you go to the doctor, your clinical information is with that doctor. You know why? Because we've spent $40 billion as a country making sure our healthcare, particularly our hospitals, are connected to our health information exchanges and exchanging data to support patient care. But due to all of the partners that we talk about in our healthcare system, many different bad decisions that were made on the public side and on the private side, that's not happening. So in California, among other states, North Carolina as well, we're making investments in providing grants for providers to connect to their health information exchanges and requiring them to use it to realize those ultimate end goals. There's also significant federal work going on with TEFCA, the Trusted Exchange Framework and Common Agreement, which I can't talk about right now. I really wish I could. And also things that are going on in the private sector that are really innovative. And Epic is taking over the world, and I don't know if that's a bad thing. What HIEs are expected to do is also changing. HIEs are, and the health data utility model, as you'll hear about from time to time, they're increasingly focused on not just the exchange of clinical information, but adding value to that clinical information, supporting data set integration, deriving clinical indicators from claims and encounters, pairing your clinical data with lab results, again, all to inform the practitioner delivering you care so that he or she has that information available to deliver you the best care they can and avoid duplicate testing, for example. Hydrating clinical data with demographic information, which is really important for addressing health equities, and increasingly cross-program eligibility. If we really do believe that someone qualifies and is eligible for multiple public programs that ultimately go to support their health, making sure that we are collecting that information and getting that information efficiently, and sometimes not relying on the patient always to have to dig it up every single time. And finally, I want to close, or almost finally, I want to close with workforce data. Across the country, California, Colorado, Oregon, Rhode Island, Ohio are using some of the data resources that I previously spoken to conduct both demand and supply side analytics to better understand their current workforce and current and future workforce needs. In Ohio, they conducted a study that found the demand for behavioral health services in the state grew at nearly twice the rate of its behavioral health workforce. They did this by collecting existing data from Medicaid and mental health claims and encounter data for demand side part of the analysis, state licensing and education data for the supply side. Other states have also used their APCDs, again, to understand the current prevalence of providers providing certain services. Workforce issues are not limited to Kentucky. A lot of the data infrastructure and tools we have in place right now. I actually saw the Kentucky Hospital Association survey, which was great to talk about vacancies. It's a little bit lagged, and it's also focused on hospital-specific workforce. States are really understanding to address future workforce needs. They need to address in more nimble and a comprehensive data capacity. And so I wanted to close on this slide, an epilogue to where we started. Our healthcare system is not working as we want it to. If we do not fix it, I do believe we are destined for broader and potentially suboptimal system changes. We cannot fix a system we don't understand. To understand a system, we require more information about its performance. We have data. We're getting better at using it. States are investing in new state health data resources, state health data organizations to support market transparency and inform policymaking. And private healthcare organizations are using new market information to advance their competitive positions. And our country is increasingly divided into data haves and data have-nots, from states to private enterprises, between those willing and able to invest in health data and analytic capacity and those that cannot. And here's my little prediction, just to close us out. I don't think this information inequity is going to last. I don't think it's sustainable. And I'm going to give you two quick, and this is I'm done. I'm going to give you two quick examples from both the public side and the private side. So on the public side, there are policymakers that I work with, and I'm, again, no judgment on either from what I'm about to say, who don't believe in cost shifting, who believe that hospitals can and physicians they need to charge what they need to charge to pay the services that provide the quality services that we demand and go to every like my son earlier today. And for those policymakers that don't necessarily believe in cost shifting, that's fine, but I just want you to keep something in mind. As other states invest in health information capacity, for other state policymakers that do feel as though we need to put more pressure on our healthcare system to lower cost growth, what does that mean at the end of the day for your state where you don't have that similar information? Where you don't have, if you don't believe that an organization can is going to be able to press on their, I think cost growth is going to shift to states that don't have information capacity, that do not have insights into their markets. And on the private side, after every one of these presentations I give, the reason I feel like health information inequities are not going to stick is because I ultimately get a call from a payer or provider really trying to understand how they can use the data that's out there to better compete in our markets. From workforce challenges to health system cost growth to population health, health data doesn't resolve all of our problems, but it does help us develop more effective solutions to our problems. And I really appreciate you having me here today. It's just so wonderful to see each of you in person, and I hope to have many conversations coming out of today. Thank you.